everyone, Assalamu alaikum. This is Dr. Tazeen, your mentor and course director at Study MRCPI, and we are here for all MRCPI aspirants who are preparing for their MRCPI Part 2 written March 2025 exams with AAA series to make you analyze your syllabus appropriately, to act wisely after a good analysis, and to achieve your success in one go. So if you have not subscribed the YouTube channel of StudyMEDIC, just subscribe now and just click on the bell icon so that you can get all the updates. And today we will be discussing about postpartum hemorrhage, which is among obstetrical emergencies. And this is very important topic. A lot of exam tested questions, they are coming from this area, and you should be able to analyze the statements of the questions appropriately. You should be able to assess that at which step you are asked to go for further management, and then you have to manage those scenarios in appropriate way. So let's have an idea that how to go about in cases of postpartum hemorrhage, and how to grab this subject appropriately. So we shall be discussing about postpartum hemorrhage in this session, and let's see that what I have for you. And before that, just keep one thing in mind, that your passion and dedication, that is the most appropriate thing for your success. Your passion and dedication is the basic ingredient of your success. So whatever you are doing and you are trying hard to achieve success, just keep one thing in mind, that you are capable of this success. And definitely these days of hustle, they are actually antidote to all of your problems. So everything would be sorted out. Just give your dedication to these last few days and keep your revision up to mark. So what actually postpartum hemorrhage is? The definition is very important. Loss of 500 ml of blood or more during childbirth, and blood loss significant enough to cause hemodynamic instability, or 10% fall in the hematocrit from the antenatal levels. So this can be asked in the exam in various ways. Hemodynamic stability of the patient is very important. Loss of blood, at what level you will say that okay, this is now beyond normal, or this needs to be taken seriously. So loss of 500 ml or more, or if the previous hematocrit was given, and now there is 10% fall in the previous hematocrit, which was the antenatal level, then you can say that this is postpartum hemorrhage. Now, postpartum hemorrhage is further divided into minor postpartum hemorrhage or major postpartum hemorrhage. Minor is basically 500 to 1000 ml, and major is more than 1000 ml. And then moderate is up to 2000. You will say that this is moderate postpartum hemorrhage. And massive postpartum hemorrhage or severe postpartum hemorrhage is when it is more than 2000 ml. Primary postpartum hemorrhage is within first 24 hours after childbirth, and secondary postpartum hemorrhage is that from 24 hours till 12 weeks after delivery. These things are important to keep in mind, that when is primary, when is secondary, when you will say that this is basically massive hemorrhage, when it is moderate hemorrhage, or when it is mild hemorrhage. Moving forward, major hemorrhage is that if the estimated blood loss is 1000 ml, or even if the blood loss is less than 1000 ml, but the clinical signs of shock or tachycardia are there, so with estimated less blood loss, then it can be considered as major postpartum hemorrhage. Prophylactic oxytocin should be offered routinely in the management of third stage of labor. And why this is important, as it reduces the postpartum hemorrhage in up to 60% of the cases. Prophylaxis for women without specific risk factors for postpartum hemorrhage delivering vaginally. Oxytocin 10 international units intramuscular injections is the agent of choice for prophylaxis in the third stage of labor. And the women who are delivering by cesarean section, oxytocin 5 international units slow IV injection should be used to encourage contractions of the uterus and to decrease blood loss. So two important differences are here, that in vaginal delivery it is 10 international units and it is intramuscular injection, and in cesarean deliveries it is 5 international units and it is IV slow injection, which should be kept in mind. Now, there can be various causes of this postpartum hemorrhage, which are basically divided into 4 T's. That there can be problems with the tone, like in most of the cases, uterine atony is among the major causes of postpartum hemorrhage. Then it can be tissues, and then trauma and thrombin or coagulation abnormalities. When we talk about the tone of the uterus, that is atonic uterus, which is the most common cause of postpartum hemorrhage, which means that due to some reasons the uterus is over distended, and now once the delivery is complete, it is taking time, or there is failure to contract to the uterus. Okay, contraction of the uterus is problematic. So what can be the reasons, or what can be the risk factors which are leading to over distended uterus? This can be multiple pregnancy, previous postpartum hemorrhage, fetal macrosomia, failed progress, prolonged second stage of labor or prolonged third stage of labor. Okay, and then it can be general anesthesia, as general anesthesia also keep the uterus relaxed, so there can be problems with the contraction of the uterus. Moving forward, there is second cause, which can be tissues, like it can be retained products of conception, or it can be abnormal placentation. Okay, incomplete placental delivery can be a problem. Placenta previa or accreta can be problematic. Previous cesarean section, previous uterine surgery, that can be among one of the reasons. Trauma can also be there, like tears, lacerations, pelvic hematomas, uterine inversions, and ruptured uterus can be among one of the causes. So where these trauma, lacerations, perineal tears, or uterine inversion or ruptured uterus, what are the risk factors leading to these situations? That is induced or augmented labor, if it is placenta accreta, if it is labor dystocia, or if it is instrumental delivery, which is leading to perineal tears or trauma. And then thrombin is present in 10% of the cases of postpartum hemorrhage. Coagulopathies can be there, preeclampsia, dead fetus in the utero can be problematic, severe infection can be there, or anticoagulation if the patient is using, that can also be among one of the risk factors that can lead to postpartum hemorrhage. Prolonged atonic uterus, elevated blood pressure, HELLP syndrome, intrauterine demise, or antepartum hemorrhage, that these are the risk factors which can lead to coagulopathies, and these are the risk factors which can be cause of postpartum hemorrhage. So what can be the postpartum hemorrhage management or optimization of the condition of the patient that can be beneficial for the patient if there is postpartum hemorrhage? So patient's hemoglobin levels should be optimized, so correction of anemia should be there in the antenatal period. If the postpartum hemorrhage is there, uterine massage in the prophylaxis of postpartum hemorrhage has no role. However, if the postpartum hemorrhage has occurred, then bimanual uterine compression in case of uterine atony can help to contract the uterus, and it can be beneficial. Active management of third stage of labor in those women who are without any risk factors for postpartum hemorrhage and they are delivering vaginally, oxytocin 10 international units, as we discussed earlier, is given by intramuscular injections, and those by cesarean section who are delivering, oxytocin 5 international units by slow IV injections is given. IV transaminic acid can also be given 0.5 to 1 gram in addition to oxytocin at the cesarean section. Ergometrine or oxytocin may be used in the absence of hypertension. Whenever there is any other drug which we are using for the management of postpartum hemorrhage, for example ergometrine, for example prostaglandin F2 alpha, Always keep in mind the contraindications. If hypertension is given, then ergometrine is not the drug of choice, and that should be kept in mind that this is contraindication, and then you have to move to the next step. If the patient is asthmatic and prostaglandin F2 alpha is given in the option, that is not the right choice, and you have to move forward to the next step of the protocol of the postpartum hemorrhage management, as prostaglandin F2 alpha is contraindicated in asthmatic patients. And this is how basically the exam questions are being tested, or this is the most common area of evaluation, that whether you know that there is contraindication present in the scenario, whether you are able to understand it, and whether you are able to manage the patient appropriately by keeping in mind the contraindications. Primary postpartum hemorrhage is the loss of 500 ml or more of the blood from the genital tract, as we discussed earlier, within the 24 hours of the birth of the baby. 500 to 1000 is minor hemorrhage. 1000 ml or more is considered among the major hemorrhage, which is further divided into moderate if it is 1000 to 2000 ml, and it is considered massive or severe if it is the blood loss which is more than 2000 ml. So there are basically the basic measures for the minor postpartum hemorrhage and the full protocol for the major postpartum hemorrhage. If it is minor postpartum hemorrhage, IV access should be there. 14 gauge cannula, one IV line should be saved, and crystallite infusion should be started, and urinary catheter should be inserted to monitor the intake and output charting. Then the full protocol for major postpartum hemorrhage is basically, first of all, is the resuscitation. And always remember that in cases of major postpartum hemorrhage, resuscitation as well as management is simultaneous. So airway would be secured, breathing would be assessed, circulation would be maintained, oxygen by mask 10 to 15 liters per minute, IV access to wide bore cannulas, patient should be flat, keep the patient warm using appropriate available measures, and then transfuse blood as early as possible, and until the blood is available, infuse up to 3.5 liters of warm fluid solution, crystalloid 2 liters and colloid 1.5 liters. The best equipment available should be used to achieve rapid warmed infusion of fluids. Special blood filters should not be used for non-blood products as they are slow infusions, and recombinant factor therapy, factor 7 therapy, should be based on clinical evaluation of the results of coagulation, and clinical judgment in each situation should be assessed. Okay, so that is something which is important to remember. Then there comes that what are the drugs which are available, that is oxytocin IV, as we discussed, that 10 international units intramuscular in cases of vaginal delivery, and then in cases of cesarean that can be 5 international units, and the infusion 40 international units in 500 ml of normal saline. Okay, then there comes basically the thing that it should be continuous infusion, and avoid undiluted rapid IV infusion which causes hypotension. Then symptometrine or ergometrine, as I discussed, that contraindications should be ruled out for this, and we can give ergometrine, oxytocin infusion as well. So then WHO recommends that unless there is contraindication, we should keep the contraindications in mind, that it should not be given in hypertension. And then if there is no contraindication, we can move forward with ergometrine. Carboprost is basically the thing which we should keep in mind, that this is not given in asthma. Okay, otherwise it can be given intramuscular 0.25 milligrams every 15 to 90 minutes. 8 doses maximum can be given, and it should be avoided in asthmatic, renal, hepatic and cardiac disease. Misoprostol, prostaglandin E1 800 micrograms can be given, and then carbetocin, which is a longer acting oxytocin derivative. Okay, IV bolus injection 100 micrograms over 1 minute can be given, which is a single dose. It should be avoided in vascular disease, especially in the coronary artery disease. The most appropriate anesthesia in cases of postpartum hemorrhage, always remember that if the patient is in a hypotension, then regional anesthesia should be avoided until and unless there is cardiovascular stability is there, or cardiovascular stability has been achieved and the patient is stable. Okay, general anesthesia when there is ongoing bleeding or cardiovascular stability is compromised is the anesthesia of choice, and rapid sequence induction with pre-oxygenation, pre-quiet pressure, endotracheal intubation should be used to reduce the risk of aspiration in immediate postpartum patient. All emergency equipments should be ready, operation theater should be alerted, operation staff should be available, so that if there is any emergency and you have to explore, so everything is available and it should be checked and readily available. So that is an obstetric emergency postpartum hemorrhage, and all the things they should be appropriate and all the things they should be ready. Okay, so then there comes the bimanual uterine compression. If the scenario is coming up that you are conducting a delivery and there is hemorrhage and uterine atony is there, so what would be the first step which you have to keep in mind? So basically that is bimanual uterine compression or rubbing up the uterus, okay, to stimulate contraction. That would be the first step. Then the next step would be emptying the bladder, so catheterization would be carried out. But always remember that if it is given that the patient has already been catheterized, if it is given that you have applied the bimanual compression and the bleeding is ongoing, then it would be next step. The next step would be syntocinon 5 units by slow IV injection. Ergometrine would be the next step. Again, remember that after ruling out contraindications, ergometrine 0.5 milligram by slow IV or intramuscular injection. It is contraindicated in women with hypertension. Syntocinon infusion 40 units in 500 ml of normal saline, 0.9% at 125 ml per hour, or if the fluid restriction is there, then it would be 80 ml per hour. So again, you have to keep this thing in mind, that whether fluid restriction is there or no, or how many units of syntocinon in the infusion, that is 40 international units and in 500 ml of normal saline. Carboprost, again keep in mind the contraindications of carboprost, that asthmatic patients it should not be given. Okay, 0.25 milligrams by IV injection, and it can be repeated up till 8 maximum doses. In after 15 minutes you can uh, give the next dose. Okay, direct intramyometrial injection of carboprost 0.5 milligram, unlicensed use at basically this is, and misoprostol can be the next step. So if it is major obstetric hemorrhage, this is the stepwise approach, that when we will say that it is major obstetric hemorrhage, that the blood loss is more than 1000 ml, and major obstetric hemorrhage or clinical shock or the signs of shock are there. So that is something which should be kept in mind. Then call for help. Senior midwife, senior consultant, anesthetist, hematologist, and blood bank should be alerted, and consultant obstetrician should be called. Airway breathing circulation would be the first step, as this is obstetrical emergency. So ABC be given, oxygen would be given by mask, and then it would be that you have to continue with fluid balance, isotonic crystalloid. You can give 2 liters of isotonic crystalloid and 1.5 liter of colloid. Blood transfusion to be given, blood products, fresh frozen plasma, platelets, cryoprecipitate, factor 7A, all these things they should be kept in mind. So monitoring, investigations, resuscitation, and medical treatment, they are side by side. Okay, so 14 gauge, 2 cannulas, full blood count, coagulation, urea electrolytes, LFTs, cross match, 4 units of blood, fresh frozen plasma, platelets, cryoprecipitate should be available. ECG oximeter should be used Foley's catheter, patient should be catheterized, hemoglobin bedside testing should be carried out, blood products should be available, and until blood products are available, fluid resuscitation should be carried out. And then again, keep in mind that you can give 3.5 liters of fluids until blood is available. That is important thing to remember. And in the medical management, it would be rubbing up the uterus. That is the first step. Okay, and then it would be then it would be catheterization of the patient. Okay, bladder should be emptied. Then it would be oxytocin 5 international units. Then we will move forward to ergometrine after ruling out contraindications. Then would be oxytocin infusion. Then the next step would be carboprost, and then the next step would be misoprostol, and then tranexamic acid. And after tranexamic acid would be the surgical management options, shifting the patient to the operation room and then moving forward. So remember one thing, in the postpartum scenarios, they are always giving the evolving scenarios, like the rubbing up of the uterus has been carried out. What would be the next step? So that would be empty the bladder. So then they will say that bladder, uterus is rubbed up, catheterization is done, bleeding is ongoing. What would be the next step? Oxytocin 5 international units. Oxytocin is not helping. What would be the next step? Ergometrine. If patient is hypertension, then the next step would be oxytocin infusion. Okay, oxytocin infusion is not helping, patient is asthmatic, so carboprost is contraindicated in cases of asthmatic patients. So the next step would be misoprostol. Misoprostol is not helping. What would be the next step? The next step would be tranexamic acid. All the medical managements has failed, nothing is helping, ongoing bleeding is there. What would be the next step? The next step would be shifting the patient to the operation room, and then starting the surgical management. Among the surgical management, bakery balloon is the first step of the surgical management. Always remember that if they have given you the scenario of vaginal delivery and medical management has failed, then bakery balloon is the most appropriate option. But if you are doing a cesarean section and uterine H-O-N-E is there, and medical management is not helping, then compression suture is the most appropriate choice. That as the patient is open, so you can go for uterine compression suture, which is the most important thing. So immediate venipuncture can be done if you are unable to get the blood sample for cross match, full blood count, coagulation, and then also for the urea and electrolytes. Renal and liver function tests, monitoring of temperature would be done every 15 minutes. Continuous pulse, blood pressure recording should be carried out. Respiratory rate should be monitored. ECG should be attached, and automated blood pressure recording should be there. Catheterization of the patient, wide gauge cannulas, available staffs, appropriate staffs, operation room should be alerted. Consider transfer to intensive therapy unit when the bleeding is controlled. Recording of parameters on a modified early obstetric warning score, and acting and escalating promptly when abnormal scores from the Muse chart, and documentation of fluid balance, blood products, and procedures. That is very, very important. Which are the fluids which we are giving? Crystalloid up to 2 liters, colloid up to 1.5 liters. Blood transfusion is indicated, then we can give O negative, RH negative, K negative red cells, and switch to group specific red cells as soon as feasible. Fresh frozen plasma is given. It should be guided by the hemostatic testing and whether hemorrhage is ongoing. If the coagulation is prolonged and hemorrhage is ongoing, then 12 to 15 ml per kg fresh frozen plasma is given. And if the hemorrhage continues after 4 units of RBCs and hemostatic tests are unavailable, then 4 units of fresh frozen plasma should be transfused. So what is the indication of fresh frozen plasma transfusion? That when you have to opt for cryoprecipitate, when you have to opt for fresh frozen plasma, that is also very, very important and exam tested area. If coagulation is deranged, and then hemorrhage is ongoing, then 12 to 15 ml per kg of fresh frozen plasma if the coagulation tests are available and they are prolonged. If somehow coagulation is not available after 4 units of red blood cell transfusion, hemorrhage is continuing, then also you have to give fresh frozen plasma. Platelet concentrates, one pool of platelets can be transfused if hemorrhage is ongoing and platelet count is less than 75, and cryoprecipitate, two pools of cryoprecipitate if hemorrhage is ongoing and fibrinogen level is less than 2, then cryoprecipitate is given. So basically fibrinogen is the trigger, or fibrinogen is the guide to transfuse cryoprecipitate, and coagulation PT and APTT is the guide to transfuse fresh frozen plasma. What are the urgent investigations which needs to be done? Urgent venipuncture if you are unable, as if the patient is in collapse, so definitely the veins would be collapsed, so venipuncture can be done. 20 ml of blood to be withdrawn for group and screen CBC, coagulation including fibrinogen, renal function tests, urea and electrolytes needs to be done. Monitoring of all the vitals, pulse, respiratory rate, blood pressure, transfer to the intensive care unit, and recording of parameters on the early obstetric warning scores should be carried out. The aim of management is that we have to keep hemoglobin levels greater than 8 grams per deciliter, platelet count greater than 75. So less than 75 platelet count is the trigger to transfuse platelets. PT less than 1.5 times of normal. So if they say that PT and APTT is more than 1.5 times of normal, so we have to go for transfusion of fresh frozen plasma. And fibrinogen levels greater than 2 grams per liter. So if in the scenario fibrinogen is given less than 2 grams per liter, then we have to go for transfusion of cryoprecipitate. So this is how you have to interpret the questions appropriately. Rubbing up the uterus, which is bimanual compression, uterine packing if the bleeding is from the uterine bed. Balloon tamponade is the first step of surgical management. And then again keep in mind that what actually is the scenario, that how to move forward. Hemostatic brace suture, B-Lynch, modified B-Lynch is without giving the incision to the uterus, and B-Lynch is that when the uterus is opened through a lower segment cesarean section, then B-Lynch suture, compression suture can be applied. Uterine artery ligation, bilateral can ligate the uterovarian. Internal iliac artery ligation, so that would be stepwise devascularization. Repair of the rupture if it is in there, and early recourse to hysterectomy if you see that the hemorrhage is ongoing, patient is compromised, so then early recourse to hysterectomy should be carried out in all these situations. So this is how basically the most common obstetric emergency postpartum hemorrhage, how you have to deal and how you have to manage this postpartum hemorrhage. I hope that these AAA series, they will help you to grab the basic concepts, that how to analyze the questions, how to apply your knowledge on the interpretation of questions, and how to answer appropriately. We at StudyMEDIC have a lot of AAA series for all of you to make your exam preparation excellent. So follow the YouTube channel of StudyMEDIC, and we wish you all the very best for your upcoming exams. Have a great day. Thank you.